Okay. If I could get our esteemed panelists to take a seat. And we'll get underway with workshop Engaging Healthcare Providers in Routine Offer of HIV Testing and HIV Management. So I think related to the last presentation on proportionate universality, this has been one of the, if we're looking at the nesting and all the different programs, I think this has been one of the very challenging but also rewarding part of the Vancouver STOP program, and pleased that we have presenters from both the Vancouver STOP team and the BC CFE. We'll do a quick rundown. I think basically what I've been told is there's going to be a series of brief presentations followed by opportunity for question and answer after each one. Those who watched me facilitate yesterday, I'm going to do a much better job of being vicious around time today. I learned my lesson, so there'll be yeah, that's the general plan. So be poised to come up and ask your questions after each presentation. So moving along here, we have Val Monroe, Operations Director, Public Health, Hospice, Palliative Care for Vancouver. I'm going to go briefer on this to give us more time to talk. We've got Rekha, Medical Health Officer. You've met everyone, she says. And if you haven't, find her afterwards and meet her. We have Afshan, began her career as a clinical research nurse on vaccine trials. I'm learning stuff as I read here. Completed a master's in public health, and currently the clinical lead for acute care routine HIV testing with Providence Healthcare and Vancouver Coastal Health. We have Misty Bath, registered nurse, working in this field as well as harm reduction, reproductive health since 2003. And we have Dr. David Hall at the very end there, family physician, working in Vancouver in a variety of settings in downtown Vancouver, as well as outpatient primary care HIV clinic at St. Paul's. And Sylvia, are you coming up after? Sylvia's hiding. Okay, we got Sylvia from the, who's the Assistant Medical Director of the Immunodeficiency Clinic. You'll see her coming up in the latter half of the workshop. And do we have Dr. Marianne Harris? Yes, also besides Sylvia, Clinical Research Advisor in the HIV/AIDS Research Program, a collaboration between St. Paul's and UBC. Okay, so with that, those are the intros. I think we're ready to go, Val, and you have 5 minutes.
All right. Thank you. I have a feeling Chiro will pull me off the stage if I take 1 second more. But we're really delighted as the VCH PHC group to spend a few minutes with you this morning talking about the work we've done around engaging our healthcare providers in a routine offer of HIV testing. As Chiro said, this has been actually one of our greatest challenges. Engaging healthcare providers in this kind of broad way to change their practice is really tough. But it's also been one of our greatest rewards in terms of the results that we're seeing from doing this work. So as I'm sure most of you in the room know, our practice, generally speaking, in the past has been to offer HIV tests to individuals or groups that we believe are at risk for HIV. So making this shift to offering a test routinely to everyone at all healthcare encounters is a very significant change in practice. And one of the first things we're asked when we bring this concept forward to our healthcare providers is, why would we do this? Our healthcare providers want, understandably, to know why they should be making a significant change in practice. And Rekha is actually going to go into far more detail on this, but in essence, we don't always know who's at risk unless someone tells us they think they may be at risk. We simply don't know, and we know that there are certainly approximately 20% plus or minus cases out there where people have HIV and don't know it. So that's obviously one significant reason. There's also the stigma that can be associated with either requesting an HIV test as a client or for the healthcare provider in offering a test to someone who thinks, oh, my healthcare provider thinks I'm, at risk. And so there's that kind of dance that can sometimes take place around offering a test. And by offering a test routinely, we can reduce that stigma. This is something we're doing routinely across the healthcare system. We know from our experience that it's well accepted when it is offered, and we've been able to see some earlier diagnoses, as well as, unfortunately, some late diagnoses for folks that, had we offered that test routinely earlier, we could have caught those diagnoses earlier. So in terms of engaging our healthcare providers, so how do you make this happen? It's certainly not as easy as sending out a policy and saying thou now shall test everyone in your routine healthcare encounters. In fact, at one point I was asked to send an email kind of like that, and it was clear to me that that was not going to achieve the results that we were needing to see. So changing practice is very tough, and I'm sure all of you have had some experience in doing that in potentially other areas, and you know that. So I've just got a bit of a laundry list here of some of the things that we think are the most important things to have in place or strategies to use as you go about doing this work. And then my colleagues here who have provided the leadership around actually making this happen on the ground will talk about their experiences in actually being out there in acute care and in GP practices making this happen, and you'll hear how they've actually used these strategies in going about their work. So visible, committed leadership, absolutely critical. You need to be ready to communicate a very clear vision and the rationale over and over. Identify and engage your champions both at the start and as you move along for maintaining and sustaining the initiative. Understand the current processes and workflows that people are using, and then build on those existing processes rather than coming in and totally creating a new system. Educate and support your healthcare providers, and often that means being there with them shoulder to shoulder, helping them in their early use of these new strategies. Provide some tools to support practice change. Anticipate arguments and have those answers ready, and we can certainly help you with that. You will get arguments, and you'll need to be very clear about what the answers can be to some of those. Collect and share your data regularly. So again, giving people that feedback of how they're doing and what difference it's making has been very, very important as we move forward with this. And then, of course, reinforcing good practice, showcasing good practice, and celebrating the successes and results that you're achieving is, again, something that is so important, and I think sometimes we tend to miss it in the busyness of our lives. So thank you, and with that, I'd like to invite Reka forward to talk with us a little bit more about the rationale.
How do I click with that? Okay, so hi everybody. So I'm actually going to start with presenting you in a very brief way with the same rationale that we came to our healthcare providers with. These are mostly our primary care physicians and other primary care providers, as well as our acute care physicians. And the reason that I want to present this to you is because of exactly what Val said. Do this because I say so, or even because the PHO says so, or because Julio Montana says so, isn't necessarily enough to change practice. What we really needed to happen is to respect the level of thought and practice that healthcare providers bring to the decision-making when they provide clinical practice, and therefore make it very clear that we've done our homework and that this makes sense in their practice for their patients. So what is the story that we brought? Well, we started with, and this is not going to be news to anybody here, but it's surprising how many physicians and nurses in the general clinical community who do not who are not familiar with HIV don't yet realize that there is a strong clinical rationale for diagnosing HIV as early as possible in the course of infection. Many people, many of your providers out there still believe that it's better not to know. And so first of all, we need to start with changing that it is actually a condition that you want to diagnose early. And a lot of the arguments that'll come for you is, well, is it better not to know? The person's day after diagnosis is going to be worse than the day before the diagnosis. The same is true for breast cancer, but it's still important to know early for the best possible clinical outcome. And how do we quantify that? You've seen lots of talks and graphs from Dr. Montana that shows that early diagnosis and treatment is the way to go forward. But again, people who aren't experts in HIV need the simple answer. And the reason I put this chart up is because I actually had a family doctor who saw this rationale 4 times. I ended up apologizing to him for having seen it the 4th time. And he said, I finally get it. And this is what I put up on my wall when somebody asks me why I offer you an HIV test. And the reason he said I offer you an HIV test is because if I diagnose you a little bit earlier and start you on treatment at CD4 count of 200 to 350, you can expect to live 16 years longer than if I diagnose you months or maybe a year later. And he said that kind of summarized the whole point. The reason I am offering you this test is not because of what I think you've done or might have done or what your partner might have done. It's because it's an important screening test that can add years to your life or life to years. In addition to that, and this was an important finding that was relatively new to many, was the public health rationale for early diagnosis. That 20% of people who don't know that they are HIV positive, as Mark Gilbert pointed out, that's not a lump of people that exist in our community. What that really means is that people who are infected with HIV spend too long in that window period of having had the infection and having been diagnosed. So that's important. But during that time, those individuals account for more than half of new infections. And that's simply because they cannot take the precautions that they need to take, or they don't take, that they would take if they knew they were positive. In addition to that, late 2011, the first randomized controlled trial, which you saw, demonstrated that it's not only that we know that people who aren't aware of their diagnosis are more likely to transmit, we can also provide a meaningful intervention that both benefits the patient and benefits their partner by substantially reducing transmission. And this is the randomized controlled trial that you've all heard about, which randomized 1,800 people into 2 arms, serodiscordant couples where one member of the couple was positive, the other member of the couple was negative. The positive patient was either given treatment right away or delayed to a CD4 count of 250. Both arms of the study were given condoms and safe sex education, and in the treat immediately group, there was 1 linked transmission. In the delayed treatment, there were 27 transmissions. So now that we're at a stage where early treatment benefits both the patient and the community, we're no longer in that dilemma of are we going to offer someone treatment for somebody else's benefit, but that which benefits the patient also benefits the community. So once you convince your providers that this is worth diagnosing early, then the next barrier is people don't know that we're not. People actually think we're doing just fine. And this is where that chart that Chris put up is really important, where you can demonstrate, no, we're not doing fine. We need to show our providers that, in fact, late diagnosis is the norm, not the exception. So we're not getting it done. And then the next chart that, again, Chris showed you, which is the missed opportunities for diagnosis, because a lot of the providers say, well, of course we're diagnosing people late. They're disengaged from the healthcare system. Many patients are. Many people are disengaged from the healthcare system, but that you can't use that as an excuse when you can demonstrate that 60% of those who are diagnosed late in the course of their infection have been seen in an emergency department, in a hospital, or have had a lab test. So again, as healthcare providers, we need to take a good look at ourselves and say, no, these are people who are seeking healthcare from us, and we're providing them healthcare for everything except for the diagnosis of HIV. And that is something that is an important message to give to healthcare providers. Healthcare providers are also, they know that they need to be responsible stewards of the healthcare dollars. So one of the things we often got is, but aren't we going to over-test people? What if I never diagnose HIV? And that's where some cost-effectiveness analyses were very helpful to demonstrate that this is a cost-effective intervention. You improve that individual's health to such an extent and potentially reduce transmission that you, if you diagnose only one person where 1,000 tests, this is a cost-effective intervention. So basically, we built a story for healthcare providers. And the other thing we pointed out, and I think was important, and this was, we talked a little bit about how doing this as a pilot project in one city made you feel a little bit unsupported, is to use the fact that jurisdictions like us, the United States, the United Kingdom, much of Europe, where HIV epidemics are quite similar to ours, all have a routine testing recommendation. So we're not making this stuff up, basically. So we basically tried to build a story for healthcare providers, which consisted of the fact that we really needed to demonstrate that early diagnosis prolongs life and prevents transmission, that late diagnosis still remains common, that those affected with HIV are being seen in healthcare. We're providing care for these individuals, and that routine HIV testing of all patients is cost-effective at quite low diagnostic yields, and that we're really just coming online with what other jurisdictions are already doing. And once we built that, one of the things we wanted to do is put it in very simple, implementable words, which is that we now recommend that you offer an HIV test to all your patients in acute and community care as part of blood work for any reason. In other words, you take that opportunity, you take that missed opportunity and choose not to miss it. And every time you test for a sexually transmitted infection, hepatitis C or tuberculosis, we really emphasize the clinical symptoms. This is where one of our biggest gaps was, that there were people presenting with clinical symptoms of HIV, but if they did not fit the provider's perception of risk, the HIV simply wasn't included in the differential diagnosis. Every time you diagnose a sexually transmitted infection, and more frequently for people with known high risk. So we built this rationale. We told healthcare providers about it in a variety of ways, probably multiple times, and then we needed to go back to what we don't mean. This is not annual testing. This is opportunistic testing. In other words, when a person is seeking care for another reason. It's not routine testing of those at risk, because often we went to healthcare provider and they said, well, I do routine testing for those at risk, which is, of course, not what we're saying. We're saying, accept the fact that our ability to assess risk in a clinical setting for a variety of reasons is actually quite poor. And this is not an abandonment of case finding based on risk and on symptoms. And I didn't put that bullet on. It's also not automatic. It's not mandatory, and it's not without consent. It's routine. It just means that as a clinician, you have established that this is a worthwhile screening or diagnostic test to offer to your patient. So that's that's our story that we try to convey. And I have some colleagues here who can elucidate for you what that's really like when you're providing that shoulder to shoulder, as well as physician and nurse leadership to your colleagues. Do you have any questions for me? Yes?
So Rob Parker from Interior Health. So we talked, so I'm all for routine testing and destigmatizing. We talked about that. But I'm just not quite sure that the approach that was useful in Vancouver is going to be useful in Interior. Mm-hmm. So if you have that out to GPs in their offices, that's great. For acute care, it's the 1 per 1,000. I mean, I think as best as I've been able to look at over the years, our prevalence rate based on known data is about 0.2 per mm-hmm. 1,000, not 1 per 1,000. And my concern would be, even if we had differential, we don't know this, if we had differential under-testing, so our rate of unknown wasn't 20%, let's say it's 40%, it's still not going to put us up right. to 1 per 1,000. And the other difference is our geography, right? So right. You've got a tight geographic area in Vancouver, a couple of major hospitals. We've got 22 hospitals or more scattered mm-hmm. all over. So if we have to put similar efforts into convincing the medical staff at Golden to mm-hmm. hospital to implement, they may go 5 years without ever seeing a positive,
That's right?
It's low numbers. So I'm wondering if our better efforts may not be placed in community access, get low barrier methods out in rural areas, nurse or lower level of point of care testing, easy blood confirmatory testing, and put more effort there, because there's opportunity costs to time spent. And I wouldn't want to spend huge amounts of everybody's time, acute care time, staff, medical staff time, public health staff, convincing hospitals to do it. If we actually get more bang for the buck, we actually find the cases in the community by community approaches. So I'm just wondering what your thoughts were about that.
So there's a couple of things. One is, you may remember that Mark's slide about the risk groups in each health authority. You actually have a much more generalized epidemic than we do. So it's interesting. We have the most concentrated epidemic, right? In other words, in terms of risk group. And we have demonstrated actually both empirically and through mathematical modeling that even in the most concentrated of epidemics, this idea that risk-based testing makes more of a contribution is actually not correct. Even in the most concentrated of epidemics, routine offer of testing has a similar contribution to different populations. So the populations that targeted testing reaches are different from the ones that routine test reaches. So I think one of the things that we've all convinced ourselves of is it's not one or the other. It actually needs to be comprehensive. In terms of the 0.1 yield, that's an American economic analysis, and I just want to point out that we're doing routine screening in pregnancy at less than 0.8 per 10,000. So in terms of routine testing or screening, we need to look at what is the age group, and when would it make a difference? In my sort of current understanding, because this is evolving over time, I would say that opportunistic testing, certainly in the 20 to 64 year age group, would make sense with either symptom or risk-based testing for everybody else. Again, this is opportunistic testing. If you apply that recommendation to me, I would have had an HIV test about once every 7 years in the past 15 to 20 years of my life. That's probably appropriate even at the lowest prevalences. The reason I think it's good to start with acute care is because if you are missing diagnoses in the community, that's where they're going to show up. If you're being missed, if you're not being diagnosed with HIV, you will eventually get sick and go to hospital. So the other thing that I think it's really important to remember that it's this idea that focusing on low barrier threshold, the low barrier testing will get it done, maintains the belief that people know their risk, will seek that care, and will know that an HIV test is what they need. So I think, for me, in that sense, I would caution against going down that path and saying this does not apply to us. I think acute care is a good place to start.
So I wasn't talking about risk-based, per se, community testing. I'm talking about routine
Testing.
community testing, especially if we've got populations, areas that don't have ready access to physicians.
Right.
And are not perhaps accessing healthcare facilities the way Vancouver populations are. So there's a difference there.
So I understand that. And Rob, I think the one thing I would say is that I think you will still access the people who know they need HIV testing. And so I think I think it's important to think through what you're saying. One of the things we said about routine testing in primary and acute care, and I think the CDC recommendations are quite good that way, is that they said, offer routine testing in these settings until you have shown that you don't have the yield. In other words, and I think that's a very good way to go, because you can't use, I don't know, as a reason to not do it anymore. So one of the things that because we had that concern come up with certain clinical settings, maybe not geographic, but really, we're not going to get the yield in this clinic. And one of the things that we've really changed in our approach is to say, that's okay. If you try this and have demonstrated that this isn't a good place to do HIV testing, then you can stop. And so we really committed with our physicians to bringing them along on a journey with us, rather than do this because we say so, but rather say, actually, nobody knows exactly what is the best place to do HIV testing. We had a lot of assumptions, and some of them were right, and many of them were wrong. And so the flavor of what we did, I think, with healthcare providers is that the evidence for early diagnosis is now so compelling that we have the responsibility to know for sure, empirically, whether or not
Yeah, I mean,
acute care is the
I
right
think
place
those
to do
arguments
it.
are all there on the clinical and the prevention side. It's more, we have quite a different region
Yeah.
geographically than you guys, and epidemiologically to some extent.
Yeah.
And there's opportunity costs, because you shared quite well how much time it took
A lot of
to
time.
convince people. So when you start multiplying that by 55 and putting time out there to get it
Yeah.
in, is that the best use of efforts? Is that where we're going to get the biggest bang? for
Well, I
buck?
think-
I'm not
Yeah.
sure yet.
No, and I get that, and I think one of the last comment I want to say about that, and I certainly understand, Rob, that different regions have different needs. The one thing that I hope will happen is that there will be a guideline, an actually provincial endorsed guideline, so you're not spending all your time trying to convince 55 hospitals that this is the right thing to do. Thanks.
Just want to quickly add that I think certainly from a ministry perspective, I think there's been some demonstrated success around the acute care piece, and just want to sort of validate Rekha's approach, where I think we're certainly hoping the policy space is now there for each region as they're thinking about a provincial program, to think about maybe it's not every hospital in their region right off the bat, but where does it potentially make sense because there's an opportunity here and the demonstrated benefits in Vancouver, and to do that rigorous evaluation and assessment and see where that leads, and then make another level or another set of decisions after doing that. So thanks.
Hello, everyone. So I have the task of describing some of the strategies that we used to engage healthcare providers, all in 4 minutes and 30 seconds now. But it's really not that easy, so I'll give you a brief overview. So for all the reasons that Rekha just described, late diagnosis, missed opportunities, and the epidemic has changed. These are all concerns and issues that healthcare providers in our hospital are actually not aware of. They're not HIV experts, and so it was our responsibility to take the information to them. And at first, I think the response was a little shocking in that the misunderstandings around HIV are still quite widespread, and so we were shocked and a little scared. But when we had time to reflect, what we realized was that this was the system that had been created, and so we needed to acknowledge that and then work on changing it. The other reason why we need to engage healthcare providers is because we had finally identified the gaps, and probably more importantly, there was an opportunity to improve the quality of life of individuals and the population at this time. So who are the providers that we needed to engage? Well, essentially it was everyone. So those who've already been doing those who've been doing HIV testing, those who provide care to at-risk populations, and then those providers who work in general medical settings. So in acute care specifically, we provided education and information dissemination to everyone from the nurses to the residents to the attending physicians to allied health staff to unit clerks and housekeeping staff. So not only was there an immense benefit from that education, but each level or each profession really had a role to play in the rollout of routine HIV testing, and I'll speak a little bit to that in the next couple of slides. So how did we do it? It's a big question, but essentially we started with engaging the chief medical health officers and the VPs of the region. And then we generated energy, we generated shared leadership, shared vision, and a bit of accountability. And then what we do is, specifically in acute care, we took the presentation that Rekha just gave and presented it to the senior executive committees, the medical advisory committees, and got their endorsement. From there, we really used the structure of the hospital system to provide the rest of the staff with the education and the program overview. So we went to monthly department meetings. We went to operational director meetings, and we provided the education, we provided the clinical rationale, we provided an update on the epidemiology, but then we also discussed potential strategies for implementation, and we worked through the process with them. So once we worked our way all the way down to frontline staff, we then engaged in one-on-one, face-to-face meetings. And this is really where the work started to be done. And so we engaged not only operational and medical directors, but we engaged frontline staff in what were the best ways to implement routine testing in acute care. And I think this was really crucial because the staff know the workflow of the environment, and you need to learn and listen from them, and then hopefully embed it into their system and their workflow. So the education, probably the most, one of the most important components of the program. It was broad and it was sustained. So we provided education for all the MDs, for the residents, for the nursing staff, for the unit clerks. To give you an idea of the extent, we provided 8 weeks of education on any given department prior to the launch of testing. So this was weekly education for 8 weeks, and then post-implementation we continue to provide monthly and then follow-up education. The education in terms of the follow-up was not only to provide a reinforcement and a reminder, but it was also a way for us to provide feedback or get feedback from staff and to provide updates on testing data and how the units were doing. We worked within the existing education and communication network. So there was really no reason to reinvent the wheel, and I think this is really important because oftentimes we get caught up in trying to create new strategies, create new frameworks. But really, in acute care, there's a very structured system, and so we used that system and embedded a lot of the education and communication into the existing networks. We tailored that education to our specific audience, and I think this was also very important. So make it relevant to who you are speaking to and make it relevant to the work that they will need to do. I know it sounds pretty simple and easy, but the reality of it is that you really need to go to where they are in that moment in time to make it relevant for them. And then maintain the momentum, and we did this in many ways. We did this by doing shoulder-to-shoulder support. So we knew that the residents didn't show up to a lot of the meetings, and I'm sure you will find this out that many physicians and nurses don't attend monthly meetings. So we met them on the units with face-to-face, brief interactions. And once they got sick of us, we provided them with books and lanyards and pens so that they would just talk to us for a little longer. And so that we could keep them engaged in the conversation and keep on receiving feedback around testing. And that's how we sort of generated our change management strategies and how we generated our data. In terms of operational tasks, what we did was we started off with a task group, and this was really the backbone of the project. And this was a group made up of clinical specialists, operations specialists, communication specialists, project managers, and we essentially were responsible for the implementation, the evaluation, and guiding any major decisions. And so I would say that this was by far the most effective working group, whereby we had individuals who were already embedded in the acute care system who were in this task group, and those who were solely responsible just for the implementation component of testing within acute care. And like I said, embedding testing into the existing workflow. So this requires a bit of background work around the analysis of workflows, and that's invaluable because when you go to your program directors and you go to the program or the operational leaders, you can open up the question as to how do you want to do this, but if you don't provide them with potential strategies or potential suggestions, it's really not a very effective dialogue. And then the other component that was absolutely essential was the delegate follow-up process. And this was really essential in that we were able to bring in public health into the acute care system and bridge the two. So we ensured that within an acute care setting where clinical providers don't have an ongoing relationship with their patients, that they could rely on this follow-up process to ensure that those patients were adequately linked to care and received the education and post-test counseling that was required after a new diagnosis. 5 minutes? 1 minute?
You're getting close to 1 minute.
Okay. So what did we learn? Well, this is the short list, really. The most effective strategy to increase continually testing was really to collect, analyze, and present our case data and our testing data. So this took, again, quite a bit of human resources in that we collected data from charts in regards to how many tests were being offered, how many tests were being accepted, and then how many patients were actually being tested for HIV. And what we found was that our acceptance rate was exceedingly high. On average, 96% of all patients who are offered an HIV test in acute care accept that test, which means only 6% actually refuse the test. And presenting this back to the leadership, and particularly to the physicians who were quite uncomfortable initially with routine testing, was a very effective strategy to increase the uptake. Healthcare providers really know their area, so listen to them and learn. The verbal offer and the requirement for a verbal offer of a test is still a barrier, but because of the high acceptance rate, I think what we need to do is easily embed the routine offer into the standard of practice and then allow the physicians to begin trying it and give them some time to incorporate it. It will not happen overnight. Introduce testing into departments where the entry pathways are simple. And so we did this by introducing testing into departments of medicine. And so we did that because 95% of the patients in medicine come through the emergency department, so the pathway is quite easy. So it was simple in terms of an implementation process. You want to begin in departments that are smaller and where the pathways are a bit simpler. And you also want to begin where you have champions, where people are somewhat engaged and excited to start routine testing. Conclusions. Well, routine testing in acute care has been a very successful project here in Vancouver. In the first year of testing, we did about over 6,000 tests at 3 hospitals with a positivity rate of about 4 in 1,000. We diagnosed individuals from late-stage disease to acute infection, and I think this touches on Rekha's point that yes, we're diagnosing people that we probably would have already been diagnosing, but we're diagnosing them earlier and we're increasing access to testing. So we're diagnosing people who are diagnosing late, but we're also diagnosing people in acute infection who regularly get tested. It's just another opportunity for testing. Then implementing routine testing in acute care will provide essentially the pulse of the community, as Rekha said. And then finally, this requires an immense commitment from the leadership, and investment in human resources, because it's not easy and you're working with a very large group of clinical staff. And this was definitely, I would say, a project that had a great impact on changing the HIV education and awareness, not only for patients and providers, but also for the general public. And now I'm ready to take questions. Great, thanks.
Thanks, Afshan. And I think you're probably available if people have questions at any time to follow up with you. Just to follow up on the rationale discussion briefly, I think, what the future holds in terms of how many hospitals in the province are routinely offering testing, it's impossible to say. I think we have to see how evaluation and what things show over time. But it's just so clear that aside from, even if X hospital ends up not in the end doing this, there just seems to be so many other intangible kind of benefits as well at a system level in terms of partnerships that have been forged and created that could potentially be used for other public health interventions, whether they're an emergency situation or more proactive. And so I think there's, as this opportunity presents itself, those benefits are, regardless of where things land in the end, are something to consider as well.
Can I just, just quickly, because I, of course, thought about it for about 20 seconds after I got off about what Rob was actually saying, and I think the point, though it is important, is we didn't start in acute care either. So I think your point is really important, that you start where you can in your community where it makes sense.
Yeah, maybe we just have some discussion. I mean, if it could be implemented by edict and it was followed by hospitals, great, right? And we didn't have to spend huge amount of time over large geographic areas. If, though, it's the latter, then it's worth discussing and thinking about.
Great. Okay, so I'm Misty Bath, and my presentation this morning is going to take a slightly different slant. I'm really going to focus on the gems that myself and my education team, I think, have gleaned over the last 2 years of helping support the implementation of a routine offer of an HIV test to some of our clients in Vancouver Coastal Health, specifically clients that were accessing multiple programs and services from primary care, public health youth clinics, mental health and addiction services, so really spanning the whole range. And the one caveat before I launch into the gems is that we're going to assume that we've secured the leadership and so leadership support, whether that's your operational directors and managers, but also your clinical leadership. So let's just assume that we have that. Which is hard enough.
I feel like I'm in physics 11, where you'd assume no friction.
So one of our gems is all about flexibility. So our goal really was to get into settings who really never had HIV on their radar. They had multiple different program and clinical priorities, and HIV was just perhaps not something that was the pressing concern. So we had to get on the radar of programs and services, and we had to get on the radar of clinicians. And our clinicians are busy. They have to meet multiple clinical and program priorities, and they're doing it in a very fiscally tight environment. So we're bringing an ask to them, and we often don't have a lot of injection of resources. So we came prepared. We had if you gave us 30 minutes, we would gladly take it, and we could blow your socks off. If you were nice enough to give us 40 minutes, then we would woo you and likely have you to go. But if you were only willing to give us 10 or 15 minutes on your staff meeting agenda, we would gladly take it. We would do it with a smile on our face and distill the key messages in 10 to 15 minutes and know who the site leads were so that we could come back and continue the work. It was really all about planting the seed wherever we could. Oh, I'm going the wrong way. So once we did get our toe in the door, we needed to build a sense of excitement and really inject a sense of urgency. So it really wasn't unusual when I was meeting with clinicians to find clinicians who were actually quite flat, closed, obviously, in their body language, and wary of the ask. They knew an ask was coming, and they didn't know how much more this was going to add to their daily workload. So I found that it was really important to help to build the excitement and that sense of urgency. And the way that I did it was that clinicians are kind of nerds at their base and love the stats and love the hard facts. And the best way to do it was to present exactly the same types of slides that Reka did, because they want to sink their teeth into the rationale. And it's something that comes naturally, I think, to a lot of clinicians. And also, not only did you need to present the facts, I've become very aware, and it no longer surprises me at all, that clinicians that aren't working in an HIV setting are truly not going to know anything about it. And so it was really important to deliver the key messages about, and I know it's really corny, and we probably have shown a lot of it's different now stuff, but really how HIV has changed and how it's different now. Everything from HIV testing, diagnosis, our treatment options, prognosis. These were tidbits of information that clinicians really didn't know much about or weren't really aware of. And so we would have clinicians sitting on the edge of their seats, asking questions, clarifying their assumptions, and creating dialogue with their teams. And we really could do it in that short amount of time that we were there. And that was enough to get the room buzzing a little bit and to have them paying some attention to you. And then to the other thing that you probably really want to hit at. At the same, on the left, clinicians love their hard stats and their facts, but they also don't mind having their heartstrings pulled by a real life story. This gentleman, this picture is probably quite recognizable, but he was a prominent AIDS activist, born in a small town in Oklahoma, moved out to California, was diagnosed with HIV and dying of HIV in the early 1990s, was estranged from his family, but asked to come home to die with them. And so he was welcomed back, and he died at home, and they had a photojournalist at the hospice. And that was his story. But for my stories, I would often share where I was as a 22-year-old young nurse, just having graduated from school and caring for a young Aboriginal man on 10C at an inner-city hospital unit, and having to clarify or checking my privilege when I was caring for him and wondering, you know, how is it that this gentleman ends up in this position, and here I am caring for him. And then wrapping him in a body bag earlier that morning and transporting him down to the morgue. And now when I relay that story, I talk to clinicians about how he presented to acute care with CD4s less than 10 and was very young, 24 or 25, and passed away without needing to. And really how in 2013, we don't need to have situations like that anymore. And it really hammers home all of the rationale that we've built up before that. And then explaining why data collection is important. So not only are you coming to teams with an ask, you're also sort of telling them, well, an external team or group of people are going to be monitoring how you're doing. What do you think about that? Which often isn't very comfortable for teams. But the way that it works is that we never presented it as a tool. We never presented it as something that would be used to single out one single clinician or to punish a team or to slam them in front of their colleagues. It was always presented as a tool for ongoing continuous quality improvement. And if we know what our baseline is and we can examine where we've come over the last 2, 3, 4 months, we can learn some really key lessons around implementation challenges, but also share best practices across programs and services. And that worked really well. And actually, we never had teams, well, in my experience with the teams that I worked with, after we explained how the data was going to be used, and after we came back and presented the data a couple of times, teams became very comfortable with us showing them their data and trying to figure out where the challenges were, what was working well, what could be tweaked moving forward. And then once you're done, that whole kind of roller coaster ride, we would leave by asking teams for their contributions. Often you've been talking to them for a while, really trying to convince them that this is the right way to move forward and that we have a clinical rationale to do it. But we would ask teams for what their contribution could be. So that could be anything from, is there clerical support that can really help initiate the process of implementation? Is there a natural site lead who could act as a champion for change? Is there an ideal go live date? Are there other program priorities right now? Are there tools that we can present to you which could help support the practice change and that naturally embed into your workflows? And can we discuss some soft targets for what future testing volumes could look like? And the teams are we just really left this with the teams, and the teams would tell us the best way that they thought implementing the routine offer of an HIV test could work in their clinical settings. And then we would go with that, and we would try it, and if it didn't work because we could see there was minimal changes to their testing data, we would bring it back to them, and we'd get them to suggest different changes. And we would also bring we would also bring the best practice of implementation strategies that were working very well at other sites to see if they could be implemented in a similar way for their program or service. And that was pretty much some of our key gems, I think. Thanks. Are there any questions? Great.
So we're going to have David come speak. As conference organizers, we did a brilliant job of needing to have Reka be in two places at once. So she actually has to leave to go to the other workshop now. So we apologize for that, Reka. And now pass it over to David.
Thank you. Hi, everyone. Thanks for coming. I just wanted to add on some of my other roles. Chiro mentioned that I work at the HIV clinic at St. Paul's. I'm also a family physician who's worked in private practice, and I'm also the medical director for primary care at Vancouver Coastal Health. And I'm going to talk about the testing initiative in family practice. So Reka and I got together and talked about how we could go out to family physicians in the community, engage them in offering a routine test for HIV. And what was great about doing that is that we had a whole bunch of experience because we had already started our acute care testing, we had already started our targeted testing, and in the primary care clinics that are part of VCH's community health services, we had already started routine testing in those family practices. So when we started thinking about how we would engage private practice GPs, we already had that wealth of information and experience. And so one of the key things when we went to talk to them and engaging them, we'll talk about how some of our challenges there, but one of the key things was to say, we're gonna make it really easy for you. We have a lot of experience, and I know you're busy, but we're going to make it really easy. We don't want it to impact your workflow, and we have tools, and we have experience, so we'll make it really easy. And so that's the message that I want to give to you. If you want to do this in your hospitals or you want to do this in your community practices, we have a ton of expertise, tools. We've had hurdles, obstacles to overcome, and rely on us. We want to make it easy for you, just in the way we've made it easy for our health partners in our region. We want to make it really easy for you. So please use our expertise and our tools and our experiences. So that was certainly an advantage for us when we went to engage private practice GPs. We had already practiced in the areas we had influence over, and we had the infrastructure and support and data collection. So in engaging a new group, what was challenging from the family practice is that we didn't have that structure. There wasn't the same associations. In our own clinics, I had the ability to say, this is an organizational imperative. There were structures, there were meetings, we had team meetings. We could get together and have a captive audience. But when you're talking about a physician in family practice, we had to go back and think about how would we engage these groups. So one of the first things we did is really rely on our existing relationships. So we just kind of went through everyone that was working with us. Do you know someone that works in this office? Hey, Misty, you know Doc you work with on the unit also has a private practice down the road. Can you ask him if we could come and give a presentation to their group? So that was one of the first ways we started out, was really capitalizing on our existing relationships. I think in your own areas, I would say, think about existing areas where there might be physician congregations. So whether that's your division of family practice, university groups, journal clubs, other study groups, dinner groups, things like that. We also paired with UBC, CPD, continuing professional development, so they had an existing network of reaching out and engaging to physicians that was a benefit to us. When we went to talk to physicians, it was important for us to talk about the overall STOP initiative and the goals, and we wanted to increase testing, diagnose earlier, treat earlier, and we wanted to connect those overall initial goals to the physician's individual goals. In their day-to-day practice, they wanted to provide quality care, help their patients be well, and so we wanted to make this initiative more relevant to them and see how it might apply in their day-to-day care of their patients. Might there be someone with undiagnosed HIV in their practice? So when we present the rationale, it's quite compelling. And as Misty said, docs and nurses love the data, and there's a lot of buy-in when we go through the data. But I think the next thing was, how is it relevant in my practice? How is it relevant to me? So that was one of our challenges, and I think our stories have helped. and appealing to physicians' and nurses' will to want to provide quality care. When we were going into physician offices, it was really important that we tried to understand what their individual needs are and what their clinic needs are. And I think it was really important that when we went to talk to them, we had expertise. So the physicians and the nurses that were going into the clinics had gone through this themselves. We were already part of routine testing. The physicians were doing that in their own practices, whether it had been in acute care or private practice. So we could say, I did it. I was nervous. My patients were really accepting. It didn't take a lot of time. I thought it would be a big nuisance to do this, but I actually worked it in and it was doable. And then as we went from place to place and we started getting people engaged in doing that, we also asked them to, people would come back and said, oh yeah, I did it, or I picked up a positive, or having this routine offer of testing really allowed me to test a broad range of people in my practice, but there were some people that I thought might have been at risk or suspected, and just having this routine offer or this guidance allowed me to have a conversation with my patients that was more open. I didn't have to worry about them thinking I was judging them. Being really flexible, as everyone has already said, was important. So we would say we would come in the morning, we would come at lunch, we would come in the evening, we would come for 15 or 20 minutes. We'd like to come for an hour, but we will work with what you'll give us, and then identifying a contact in the clinic so that we could keep a relationship ongoing, and saying, we are going to make this easy for you. Whatever you need, we will try to provide for you. Bringing data was really important, and we've been saying that over and over again. And I think we bring our epidemiological data to help people understand why it's important. We can bring aggregate data in terms of what we're picking up in acute care and other targeted settings to help people understand what we've already been achieving. But we also had the ability to tell the individual clinicians, I can give you your own data, not to measure you, but to provide you a tool so you can see how much you were testing in the past and how much you're testing going forward. And that was a really important part for also maintaining routine testing. So we could bring a report back at a regular interval, and that would keep people engaged. So we've sorted out all of those processes, and we want to provide that knowledge and expertise to you as well. The relationships, like I said, were very important, meeting face-to-face, making phone calls, capitalizing on existing relationships. Follow-through was very important. So we wanted to appear that we were bringing in a very polished project or product. And when people said, you know what would work really well for my clinic would be if you could help build us something into our EMR that would remind me, or we would like a laminated handout for the waiting room or a sign for the clinic room, we would say, no problem, we can do that. We have some of that, and if we don't, we're going to develop it. Who's your contact? We'll bring it back. We didn't have to say, okay, why don't you work with us? We'll bounce some ideas around. We'll develop it with you. We said, we'll take care of it. And we would bring them back what they asked for. So they really felt like there wasn't a large burden placed on them. So I think I wanted to just elaborate on getting a physician in a practice to understand how it might be relevant to their own practice, because that was one of our challenges. We first talked about the barriers. I might feel uncomfortable to offer it. My patients might not accept it. But after we got through all of that, the next was, yeah, I think that's all important, but I really don't know that this is applicable in my setting for my patients. And I think what was useful was people who had picked up positives in low-risk settings or where there was a surprise, so we told those stories. And I also had the advantage of being a HIV care provider, so I could talk about some of the patients and some of the stories where there may have been a missed opportunity. And one of the stories that I like to tell is an elderly couple that I have in my practice. The gentleman was picked up in an acute care setting through routine testing. He was admitted to a surgical ward for a surgical problem, and he had actually quite advanced infection and very low T-cell count, and there wasn't a lot of direct HIV complications for him at that time, but he wasn't feeling great. And his wife was tested as part of the public health contact tracing, and she was also positive. And she had been interacting with the health system quite a bit. She was fatigued. She had very low platelets. She was having GI bleeds, easy bruising, bleeding gums, dizzy, just didn't feel great at all. She had been in and out of hospital under the care of a specialist for her blood disorder, and that disorder was a symptom of her untreated HIV infection. So both of them now have their HIV infection treated. They're both feeling so much better. She's not bleeding and having to go in and out of hospital all the time. And it's stories like that that help physicians understand the impact that they can make by picking up someone that they might not have suspected or known to be at risk. And I have a whole host of other stories that we pick and choose for depending on the groups we're talking to. So I think it's really important also to identify champions. So in our groups that we engage, you can always see there's a little glint in someone's eye. They really have a lot of buy-in, so we try to bring them in and ask them to help us engage other groups. And part of what we've been doing with this is increasing testing, but if we're going to be picking up more diagnoses, people are asking us, well, what do we do? Maybe I want to treat them. How do we get them into treatment? So we've also tried to create champions in the community, whether it's within our own primary care centers in VCH or some of the private practices, to give physicians the opportunity to also get education around management of HIV infection. So I know that Dr. Guillemi is going to talk more about that, but we worked together to connect those champions who wanted to learn more about HIV and really get involved in treatment and management. So maybe I'll stop there for time reasons and open it up to questions.
I might be the only person in the room that doesn't know the answer to this question, and if so, I apologize. I'm a family physician. I'm contracted by Northern Health to provide HIV primary care and have done some system development. But I just wondered if you could catch me up on, I might have missed the moment of knowing this, what has been the transition from formal pre- and post-test counseling to the antithesis, which is a newsletter that comes from UBC CPD, and the little thing that says, "This changed my practice." And there was a physician in there who said that how she has found the way to offer HIV testing is, she says, "May I add an HIV test to your blood work today?" End of story. So that's two ends of the spectrum. What is your expectation?
Yeah, so what we realized was the lengthy pre-test counseling process and the need to have a detailed informed consent process for HIV testing was a barrier to testing. And in a routine offer where we haven't had a discussion about risk at all, so we're not saying for our routine testing, abandon your risk-based approach, where those discussions are probably important and meaningful. But if it's just a routine offer, we didn't even have a discussion about risk. I think it's important because this is a serious problem in our region. I'm offering it to everyone. The medical health officer in our region has made a recommendation that everyone be tested. I'd like to add it to your test today. Is that okay? Yes. Here I have a handout. There's a health file that we have in our resource toolkit that goes through all of the key points that would cover that informed consent process. So that is our process, and we've gone through the development of that to have all of our checks and balances to make sure we're doing the right thing and that physicians or other practitioners are not putting themselves at risk. But in the routine offer, we saw that that detailed discussion was a barrier. So now just offering, providing a health file meets all of the needs.
David Forrest, Infectious Diseases in Nanaimo. Thanks very much. And first of all, I just wanted to preface what I said or what I'm about to say, by saying that I'm actually quite committed to trying to improve routine testing. I've spent some time talking to Rika about this, about trying to introduce this in Vancouver Island as a universal thing across our region. But first question, and this is really for the panel, is can you tell me what what incremental benefit, or at least in terms of test positivity, there has been by routinizing testing over in the acute care setting over what it might have been achieved by routinizing testing of those with risk factors. Do you know how many more were picked up simply because the test was routine as opposed to picked up because we routinized the test in those that had the risks, identifiable risks?
I'm not able to answer that directly. I think we're better poised to know that in acute care. Our challenge is in community. I can tell you how much more you're testing, but we don't know when we get a test result, was it a routine offer or not? So I think we're a bit better poised in the acute care system. I think Megan wants to maybe help me answer the question.
Hi, sorry, great question. So I'm Megan Shumath, and I was the lead for implementing in community settings. And we did analyze that, so I'm happy to get you the exact data, but it was quite a noticeable impact. So we doubled testing in our community setting. So I think it also speaks to the earlier point of Interior. We didn't just implement in acute care, we did implement in our detoxes and our mental health outreach teams. And it was a fascinating experience of the sites where you probably think routine testing might be happening, but it's not. And the yield, as you saw earlier in the EPI presentations, HIV diagnoses are going down every year. And so we didn't see a dramatic doubling like we did in acute care. Acute care actually saw double the yield than they did before routine testing. We saw an increase, but you would expect a decrease, and so a modest increase. And in some sites, that sort of staying at the same level. But we also know from the cases that we analyzed and from our experiences with the clinicians that there were patients they wouldn't have offered a test to. So, 16-year-old heterosexual young boy was someone who was diagnosed in one of our primary care settings, just patients that they were not doing risk-based testing with. And because we also are public health, we were analyzing each case as they came in, and so it was we actually kind of coded them as this was a routine test or this was probably a risk-based screen, and we'd be happy to share that data. But I think all of the clinicians can get behind the idea that you should be offering a routine test in sites where patients from key populations are frequenting. So the idea that our detox wasn't testing when the primary amount of patients there are people who use injection drugs. I mean, even if you are still struggling with this idea of routine testing for the general population, you'll be shocked when you start doing your project where it's not happening. It's not happening in our jail, it's not happening in our mental health teams. And your question about pretest counseling was great because I had patients tell me, I like this approach better. I don't like being interrogated about who I'm having sex with and who I'm sharing needles with. We don't like the experience of the interrogation. We prefer this sort of simple routine offer. We also found that the clinicians were very grateful. In my mental health teams, the doctors said, patients would ask me for a test, and I would say, sorry, I can't give you one. You'll have to go to the STI clinic. I don't know how to do pretest counseling. And so that was really shocking. And this is our inner city, mental health team serving primarily people with mental health and injection drug use issues. So as you start to sort of demystify this, it's work, but you'll have the help of a policy. At the same time, there are a lot of vulnerabilities and marginalization. So there are settings where the pretest, we call it discussion now, is absolutely crucial. And your clinicians are experts at working through that. And so it's not to say you don't do a pretest discussion if someone asks questions. It's not to say you don't take the time if someone's very marginalized and needs to really think it through. It's not a mandatory test. It's an offer, and often there is a discussion.
We're going to have to pause this, and hopefully there can be ongoing discussions over lunch. Afshan, did you have a quick piece you wanted to add as Dr. Guiliemi's getting ready to talk about management and treatment?
Sure. So as part of acute care testing, we were able to monitor testing volumes and positivity rates from baseline. And what we found in acute care is that we increased testing fourfold on average from baseline. So we compared it to 3 years prior to, and we we increased our positivity or yield either doubled or more than doubled on a yearly average from baseline.
Okay, well, thank you, and thank you to the organizers to invite me and Dr. Marianne, my colleague, Dr. Marianne Harris, to talk a little bit today about the educational initiatives from the BC Centers for Excellence. Obviously, this is a switch of what we were talking, but I think it's a lot of common ground between the issues of expanding testing and education. And the reason why I'm saying that is that you should know there is no formal education for our family physicians from the universities to treat patients with HIV. So as we try to promote education and training with family doctors and other clinicians, we certainly will have an impact in how comfortable they feel about dealing with HIV-positive patients and consequently offering testing. So I think it's a bit of an overlap and it's an important issue. So saying that, as you all know, the BC Centers for Excellence has been always involved in treatment of HIV-positive patients. But as part of that, we also are very passionate or interested in knowledge translation. The knowledge translation from the centers has been usually reflected in providing clinical guidelines and expanding the research and letting people know what we're doing. But my piece is the clinical education. And we all realized that, as I mentioned before, there was no formal clinical education for providers. And when we developed the IDC, the Immunodeficiency Clinic, with Dr. Barrios and others, we found that that was the ideal site to train clinicians. There is a lot of expertise. There is a huge volume of patients that come with multiple problems, and we have a fantastic multidisciplinary team that is a fertile ground to provide appropriate training and education for all the clinicians. So with that in mind, I'm going to run through my slides so I'll leave enough time for Marianne to do her piece. But essentially, in this graph, what I'm trying to explain is that we conceive the clinical education in three main parts. One is educational events that I'm briefly going to describe some of them. So there are the meetings and the different events where we provide updates on different issues related to HIV management. We also have the ongoing support for healthcare providers, and Marianne will talk a little bit about that when she talks about the guidelines, but it's other resources that I'll explain in a minute. And finally, the training programs, and we have trained a significant number of physicians and other clinicians that I will describe. So I went too fast. In terms of educational events, we provide and many of you have been there and know these semi-annual HIV updates in June and December. And thus, the idea of these seminars or these days are to provide for healthcare providers an up-to-date of what's happening in different issues related to HIV. We also do bi-weekly AIDS care rounds at St. Paul's Hospital. Those rounds are taped, and everybody can access those through the website, but as well provides CME credits for physicians that participate. We as well have IDC journal clubs. Now we incorporated these articles and the discussions of the journal clubs in our website. So if you're interested to know what is new or what articles we've been discussing every other week at the IDC, and usually we focus on multidisciplinary aspects of HIV care. So it's not just physician-oriented. Our discipline, other disciplines like pharmacists and nurses also participate on there, so you will see important or new articles related to that. And the centers as well is involved in the forecast lectures, so those are more research-oriented but very interesting. So in terms of clinical resources for healthcare providers, we have an online course. So this course has been now updated. It's the on HIV diagnosis and management. Participants that take the course will have, I'll tell you more about that because I think I have another slide on that, but it's been updated recently. We also have a REACH phone line. The REACH line is a easy access for family physicians or healthcare providers that want to know, want help in the management of their patients. So this is a 24/7 line, and us, the physicians at the IDC, are on call regularly to respond to that. Also, this email that you can send us, or an email address you can send us if you have issues with your patients. And then is the clinical guidelines. The clinical guidelines have been in place now for many years, and we keep updating them. More recently, we updated the HIV, we developed the HIV primary care guidelines, and again, Marianne will talk a bit more about the mobile version. We are about to release the new therapeutic guidelines, and as well, we have opportunistic infection guidelines and accidental exposure guidelines. So these are our tools that are accessible to anyone that goes to the center's site. With regards to the online course, I just put an extra slide because it's relatively new. So we had 10, the course is composed of 10 learning modules. Each module is done by one of our experts or specialists in different areas, and you can see in that slide the topics there. All the topics are relevant to HIV management. It's a self-evaluation quizzes, so at the end you do the quiz and you get feedback on how you did with that. And for physicians that want to do that, is CME credits that you can acquire through that. It's actually a requirement as well for our preceptorship, so I'll talk about that in a minute, but we request that people that participate in formal training do this online course. And the registration is done through the BC CFE. So now I'm going to focus in the training per se, what kind of training we have provided to clinicians. So we've been involved with the Vancouver Coastal Health Authority in an intense preceptorship program. This was part of the STOP program. So I'll talk about that in a minute because that's the latest one, but also we continue to provide preceptorship programs for nurse practitioners and to family physicians through the UBC's Enhanced Skill programs, which is a more extended type of preceptorship. So family physicians throughout the province have participated in that third point in the UBC program. We as well provide an interdisciplinary UBC course, and that's something that my predecessor, Irene Goldstone, had initiated, and it's a group of other organizations involved in this, and it's a comprehensive course for other healthcare providers. And also we have an elective rotation. We are a site for family practice physicians or residents, as well as community medicine and other residencies that come and spend some time with us. So in terms of the clinical training programs, as I mentioned earlier, we are an ideal site, so physicians or clinicians come to the IDC and participate in the primary care, as well as the HIV specialist clinics. They as well can choose to go to the AIDS ward or external sites that are mentioned there. So we provide a variety of sites for them to train. What's our outcome? But we've been doing this for 8 years now. So we had trained 61 healthcare providers, particularly nurse practitioners and family doctors in those 8 years. And I described there the different programs that they went through the UBC Enhancement Skill Program, community physicians sponsored by health authorities, mainly Vancouver Coastal, but some of you know that have come from other health authorities, and also we had that special intense preceptorship with Vancouver Coastal. As well, we had trained 15 nurse practitioners that now are allowed to, or they can renew antiretroviral prescriptions, so that's part of the training. With regards to and this is my final piece, with regards to the Vancouver Coastal Intensive HIV Preceptorship Program was designed for family practitioners as well as nurse practitioners. The program consists of 3 modules. One is the online course, as I mentioned earlier, so they all have the same baseline knowledge, and this online course is we try to make it as basic or as possible, so when they come to the clinical side, they have some understanding of what we're talking about. The second module is a 1 week in the clinical sites, and the clinical sites are the ones I described earlier, mainly the IDC, the 10C ward, O3, etc. So they spend 5 days with us, and during those 5 days also they have a lunchtime symposium where they do one-on-one meeting with some of our experts, and there's case discussions. And finally, we have a third module that we incorporated later, which is the clinical mentorship. So once you finish this training, you are not on your own. You can call us. You will be attached to a mentor that works in the clinic, and we will try to help you to follow up with those patients. And that's approximately 3 to 6 months, depending on how comfortable you are managing in your own clinic. What are the outcomes? So these are outcomes only for the Vancouver Coastal Intensive Preceptorship. We trained 26 physicians and nurse practitioners between September 2011 and September 2012. So that was in a year. Out of the 21 surveys that we received, because we asked them to send us evaluations, 52% say that they were highly satisfied, and 47% they were very satisfied with the training. Also, we could go back and look at the data, and so we look at data from the centers and review the number of prescriptions that these trainees have filled up after their training. Only one trainee had prescribed antiretrovirals before he was trained, and he only had 2 patients in their practice. Once they completed the treatment, 12 family physicians initiated 45 patients on antiretrovirals, and 13 of them, which were 3 nurse practitioners and 10 family doctors, refilled 162 prescriptions in the period of a year. So I think that's a very positive impact. This is a very compact program, very intense, but have provided these clinicians enough confidence to go back to their practice and start to assess and to provide antiretroviral therapy. So I want to show you this data to show how we could have an impact in the education of primary care providers and how we need to have a structured system to provide this education, and we need to keep supporting it. Finally, there is other initiatives that we want to develop, and we're working on that, webinars as well as online and telemedicine for consultations in the remote areas. And here is the information that you need to know, which is how to contact us, how to access our website, how to send us an email if you want to train or have people that you know that want to train with us. The Reach line, that's a support line for community providers or physicians that want to that have patients on their care, and my email. Thank you.
Thank you. Dr. Harris. I will put that slide back up after Dr. Harris has spoken, because I see people feverishly writing.
Thanks. So I'm Marianne Harris. As I said, I work at the AIDS Research Program at St. Paul's Hospital, and I also have a family practice background, and I realize I'm the only thing standing between you and lunch, so I'm going to be very quick, but I think you'll find this kind of interesting. Coming from a family practice background, I realize that clinicians are not going to order a test if then they don't know what to do with the patient if the test comes back positive. So it's a disincentive for HIV testing if you've never seen an HIV patient and you don't know how to proceed from there. That was one of our motivations to develop the primary care guidelines, which are a relatively new document for the CFU. For a long time we've had antiretroviral therapy guidelines, but not really primary care guidelines, which go through, you know, how do you manage a patient? What tests do you do? What immunizations should they receive, et cetera, et cetera. So that's sort of the background of this. And the other piece of that is that, of course, these guidelines have to be accessible, they have to be user-friendly, they have to be quick. Traditionally, the CFE guidelines have been in a PDF format available on the website, which is lovely, but not really very useful for the general busy doctor in the clinic. So we wanted to make that a bit more user-friendly. So the primary care guidelines themselves were developed by a group of people, including Dr. Barrios as the chair, and with input from the Positive Living Society of BC and the Dr. Peter AIDS Foundation and others, as you can see here, and also with input from some physicians and beta testers all across the province. We completed the original version in March 2011, which again was posted as a PDF, and then more recently turned this into mobile guidelines that are available on computers and mobile platforms, and that was launched in November 2012. Some of you are already familiar with it, and so those of you who have your iPhone handy can click in this number right now. I'll show a demo for the rest of you in a minute. I just wanted to mention these are the devices that are supported that these guidelines are available on. So pretty much everything. So, you know, whether it's a handheld device, an iPhone, an iPad, if you happen to have a desktop computer in your office, this is a resource that you can access as well. So I won't go through the topics here, but if I can just, can I go back and click on that link, and we'll see if we can bring it up here. So that's the website, and you should also be able to, there we are. You should also be able to access it through the main CFE website. So this is what it looks like if you open it up on a laptop, and if it's on a smaller device, it'll look something like this. So this shows you what the document covers. So it covers assessment of the HIV positive patient, history, physical, etc. It goes through management, immunizations. Antiretroviral therapy is just a small piece. This is not the antiretroviral therapy guideline. That's a separate document. But it talks about monitoring, prophylaxis. It has lifestyle and psychosocial issues. And then finally, some special topics like acute infection, special issues in women, addictions. It has sort of a summary of everything in terms of a schedule of assessments and procedures. There's also a section with which we're working on expanding with information for patients, so stuff that you can provide to your patients when you see them, and also resources for referrals and so on. So just to look at one of these sections, for example, history. Do I do yes or no here? Yeah, I would say yes. Yeah, exactly. There we go. So if you click on history, it gives you this information, and it's got hyperlinks to other places within the document, as well as to relevant phone numbers. And so this goes through, actually, this is not exactly what, this is the laptop version. This is not what it looks like on a mobile device. But anyway, so it goes through all the different components of history. And then you can go back to home. If I can make it smaller, then it will give me a better view. Sorry, I'm not, there we go, that should work better. I'll show you the coolest one, if this will work here. It's in acute infections, isn't it, Sylvia? Yeah. So if we go to acute infection, this is wonderful, everybody loves this one. Diagnostic tests? Diagnostic tests, yeah. So we click on diagnostic tests, and so it tells you which tests become positive at which different phase following infection. So days since infection, 7 days since infection, your RNA and AAT starts to become positive, and see as you slide it along, you know, if it's been 18 days since your person encountered HIV, these are the tests that are going to be positive, et cetera, et cetera. Isn't that a cool little thing? We love that. Anyway, that's more sort of fun than anything else. But, you know, if you go on here, it gives you signs and symptoms of acute infection. So tons of useful information in here. So please do have a look at this when you have a chance. Go through with all the different areas and get an idea of what is in there. We think it's going to be something that's going to be very useful to clinicians. This is the schedule of assessments and procedures. So, okay, I have a person who's HIV positive. What are the baseline tests that I need to do? Click here, it tells you. Okay, from history and physical, the important things to look at, blood test, chest x-ray, et cetera, et cetera. And then it will tell you what things you have to do every 6 months, every annually, less than annually, et cetera. And then just the one other section I wanted to show you, just to give you an idea of this, is the resource section. which we just recently posted, actually. This is very much a work in progress. So if you do look at this and you have comments or suggestions, whatever, we're more than happy to get your feedback, because as I said, it's relatively new, and we're working on it as we move along. So the resource section has useful resources for healthcare professionals, things like BC 211, the BC CDC, or the CFE drug treatment program, the lab, the REACH line that Sylvia just mentioned. So if you go on here and you click on REACH, of course, if you have an iPhone, it will just dial the number for you. Isn't that an amazing thing? And it also has web links as well. It has the Oak Tree Clinic if you have an HIV positive woman who's pregnant or planning to become pregnant or something. And then there's also a list of resources for patients. So, I'm out in the community, I have an HIV positive patient, what AIDS service organizations are out there that might be helpful in providing support. This is not an exhaustive list. We didn't want to put every single organization in the province because we thought that would be sort of overwhelming, but these are sort of the major resources that then will refer people on if there are more appropriate organizations in the community. And so you can have a look at all those different things there. So we think it's going to be, really a useful and helpful thing for clinicians that are, I actually look at it myself a couple of times every day. And importantly, we're going to be doing a similar thing with the other guidelines, like the antiretroviral therapy guidelines, which Sylvia mentioned, that we have just updated. They're going to be converted and accessible in the same format, as well as the opportunistic infection guidelines, the accidental exposure. All this will take time, but our aim is to ultimately have all of the CFE guidelines available in this nice, compact, and hopefully user-friendly version. So again, please take the opportunity to have a look at it, check it out. If you have feedback, my email is the same as Sylvia's, except M. Harris instead of S-K-M-E. So please, you can send feedback to her and she'll send it to me. That just a great resource, I think, that you can let clinicians know as they're doing HIV testing in their patients. Thank you very much, and glad to take questions if we have time.
Well, if there's a final question, I'll just... If not, well, thank you to Sylvia, Marianne, to the other panel.